This is a 66-year-old woman that has a history of advanced hallux rigidus. Many years ago, she had a cheilectomy, and over time, the arthritic condition has progressed. So she presented essentially with painful, limited motion of her hallux. She has approximately only about 20 degrees of dorsiflexion. Throughout that range of motion, from 0 to 20 degrees, painful. She also has she had a positive first MTP grind test, and you can see the rather large prominence overlying the dorsal aspect of the metatarsal head. This is an alternative to an arthrodesis. She was offered an arthrodesis or a joint-sparing type procedure. This is total toe arthroplasty, in which we're using the Arthrosurface ToeMotion total toe, which is the complement to the previous handicap DF, which resurfaces now both not only the metatarsal head, but also the phalangeal articular surface. Obviously, the benefit of not fusing the joint would be in an effort to retain or preserve whatever motion they presently have, and also to build upon that and try to get at least another 20, 30 degrees of dorsiflexion so that you have more or less a painless arc of motion. Arthrodesis is a very good procedure for pain relief, but as you know, it comes at the expense of sacrificing whatever motion is left of that joint. So we come straight down, we approach it. She's had some previous scar tissue from her previous surgery. The EHL, we're going to take lateral. So we're going to just go just medial to the, just lateral to the EHL. We're going to write down on the joint capsule. We sharply dissect down. Then we're going to reflect medially and then laterally. What we found over time in doing these cases is that we've gotten more and more aggressive with the soft tissue releases than we did prior. These joints, unlike some of the hallux valgus cases we do, are rather tight joints, very contracted, and trying to get as much motion as you can on the table, and then doing some soft tissue balancing is, we're finding is very important in terms of the amount of motion that you have post-operatively. Also, we've been more aggressive as well with the post-operative rehab. You can see here the rather large osteophyte that we call the medial eminence. There's almost complete erosion of the articular surface of the metatarsal head. Whole dorsal aspect, central aspect, even down into the plantar aspect, there's thinning of cartilage. And if you kind of look down here as well, you could say the phalangeal side is also significantly involved. You come all the way down to at least the central aspect. We've developed our own criteria for classification, and this would be what we'd call 3B, possibly 3C. So the first step is we're going to put a guide pin in the metatarsal head. I'm going to release a little bit more along this capsule. We're going to release a little bit as we go along. Now, two ways you can do this. There's a spherical guide, which you can place with the footprints, the feet on the dorsal and plantar aspect. You can seat it right against the metatarsal head and place it this way. Now, with time, we've kind of found that that you could also do this freehand. You kind of want to base it right over the crista. So what you'll see oftentimes is the guide pin. It will look like you're starting more lateral, but what you're really seeing is that there's the medial eminence makes it look like you're starting too lateral, but this is more or less the center of that joint, especially when we check it. Like I said, use the crista as a reference point. Now, if we like this guide pin, the next step would be the drill, step drill, and then the tap. And you want to ream this down so that the shoulder of the drill flush with the remainder of the articular surface. We're going to tap to this etched line. And hold the foot like this. And then the next step is to put the screw in. And this tapered screw gets a very good purchase. And this is the key. I think this is one of the key to this design, how this design differs from many of the other implants out there for this joint, that you really truly get immediate fixation rather than a peg or stem with this taper screw. Now I'm down to the surface with the etch line. I'm going to decompress this joint 2 to 3 millimeters. So typically what we'll do at this point in time is we'll take each quarter turn is in a millimeter. So I'm going to take this and I'm going to do either a half to 3/4 turn to give it an extra 2 to 3 millimeters of decompression. So that's a half a turn. That's about 2 millimeters. But typically, you could take this out and you could put this in, and you can kind of measure the articular surface. And when you do the reaming, you want to start the reamer before you hit the surface, and the reamer will stop. It's got an internal stop, and that's basically the screw. The screw will stop it from going further. We have this reamer, dorsal reamer, which will carve out exactly what's based on the handicap DF. This reamer will fit into the shaft. So I'll have somebody kind of dorsiflex the foot, make sure that I'm lined up, that I'm not either pronated or supinated in terms of this reamer. So we'll load it like this, and then we'll hook up the drill. And once again, this will ream this surface. And this has a stop as well to it. Okay, so we're down. Okay, so now we've carved out, let's say, let's say chilectomy, this part that will match the implant. So now this is prepared now for the metatarsal implant. And we're going to remove a lot of this remaining medial laminate. Okay, this is a trial implant. Okay, this is a 2.5 by 4.5, and once again, the 4.5 it represents the degree or inclination of that slope on that dorsal articular surface. Pop that in. Okay, so I'm going to remove any excess bone on the sides here. So essentially, now the metatarsal side is prepared, and at this stage, you know, if we were just doing, let's say, the typical handicap resurfacing on one side, then we'd essentially be done. We'd just be putting in our formal final component in the metatarsal. This condition often involves both sides of the joint, so we're hoping that with the addition of the matching phalangeal implant, that this will give us more predictable pain relief in some of these patients that really have, that you have to address both sides of the joint, you know. Now that I got this better prepared, now you can kind of get in here a little better with some of your releases. So I'm kind of using, in this regard, I'm using a Montgomery elevator to kind of get between the sesamoid and the head. So now you can kind of see that's kind of really loosened it up. Okay, now we're going to prepare the phalanx side. So either with our trial in or out, you can kind of see that we've opened up some joint space, and we're going to end up doing the phalanx side as well. So bring it up here, you can kind of already see that we got decent motion going up. So this is with the trial in. So you can almost get up to 90. Now that'd be great if you didn't have an articular surface that looked like this, you know. So that's the problem. So you can certainly gain motion, but you got a surface that is also very arthritic, you know, down to, let's say, encroaching on the central aspect. But I think with the coming of age with this implant, it should help us really address this more like some of the other joints that we address in orthopedics. We're going to now prepare the phalanx side. Let me just pop out the trial here for a second. I just say you just got to be careful when you take that trial out, because you don't really want to mess up the preparation that you have there. It does give you definitely more room. Okay. When you place this, you have to kind of really be dead center on both planes. So I like my position. Like I said, we're going to advance this just so it engages the distal phalanx as well. Mainly just to anchor it so that we don't have any change in our guide pin when we do the drilling and reaming process. Now the phalangeal preparation involves a step drill. Okay, so you can see we're going to drill. Part of it's for the shaft, and then part of it is for the articular surface as it widens out. said, I think it's an important step to advance that pin just past the joint. The tap, once again, this bone, the phalanx, can get pretty tight, so I like to get a hold on the toe itself. Okay, so I can kind of feel the torque that's going through it. About that, right? One thing I forgot to mention in preparing the phalanx surface is the phalanx subchondral bone can be very sclerotic, especially when it becomes arthritic. And just beyond that subchondral bone plate, it becomes very cancellous and can be very soft. With the screw here, we want to loop this around the base. So this comes separately, and then you have your phalangeal implant. So you want to loop these around each side of it, and then you'll screw this in to tighten it up, okay? So when I bring it like this, okay, like it, you get excellent torsion. You feel how, and it slides out. So now we've seated the phalangeal implant. Like I said, it gets a really solid fixation. We're definitely covered plantar, okay? And the way, as long as you get it seated very, very nicely in and around circumferentially, you may get a little bit of uncoverage dorsally, but I wouldn't be that concerned about it because you get such a solid bite, such solid purchase within that phalanx with this, with that tapered screw. We got our phalangeal implant trial in, we got our metatarsal implant trial in, and now we're going to trial our polys. There are two different thicknesses of polys. There's essentially 1 millimeter and 2 millimeters for each size implant. So it's a modular system. Let's try the one first, and then we'll pop into the two, and we'll see which one we like best. Okay, so this is the 1 millimeter. I'm going to seat this in here. Okay. Okay, so this is with the 1 millimeter. You get very good motion. You can see you can kind of come, you get congruent surfaces, you come to essentially almost 90 degrees, and it's fluid, smooth motion. If you feel catching, then it may be two things. It could be either on the metatarsal side, you may have to smooth out the surface of where the crista is, or if there's any excess bone along the plantar aspect, like a ridge, that looks excellent. So we can trial this, and we can pop this out. We can try the two as well. But that really gives excellent motion. Let's pop this out. What you do with this is you attach this to the suction device. That will hold it for you. I kind of line this up with the line here. I line that up with the head, and this kind of fits right over top. You detach the suction. Okay, and we get a little tamp, and that will seat the implant. The two components of the metatarsal implant is a Morse taper screw, and it's basically a Morse taper interlock with the head. So, actually looks quite nice though. Now that we have the formal implant in, we're just going to trial again the two components. You really want to clean out the bottom surface too, make sure there's enough. Do a final check before you do everything. In terms of any little loose mice, bone fragments. This is the size 2 implant, 2 millimeter. Fits nicely as well. You're just going to end up getting a better feel as time goes along for what's right in terms of the feel. But I think in this case, I think I'm going to go with the 2. I think it's going to give it good stability, and even with the 2, I think she's got good motion. And I think dropping her back 2 to 3 millimeters with our decompression, I think the 2 will maintain our length a lot better too. So we're going to take this out, little irrigation. Okay. So here's our poly. Once again, you want to make sure there's no soft tissue between the implant so you get a good lock. I'm spinning this so that the line is dorsal. Okay. Let me get a little freer and roll this in. Once again, you want that etch dorsally. I'll slide this down. Okay, now we kind of developed this as a delivery system so that we wouldn't have to pound on the poly. But once again, you want to make sure that that's lined up right, and then you just turn this thing, and we should feel it pop in. You'll feel like a clunk. Yeah. There. So that's it. I'm loosening this up a little bit. I'm going to cut each side of the suture. Okay. Cut the finer one on the other side. Good. And then if you just spin this, that will slide out by itself. You can see it slides that suture right out. Voila. There you have it. I think it's one that you're going to be able to move early, and I don't think we're going to see anywhere near the loosening rates that we used to see with those older generation implants, and even some of the ones that are out there now, just because of the fixation and the respect to the anatomy. In terms of the motion, you see really smooth gliding motion. Got no restrictions. Okay. Loading it as well. See, it comes up. Very smooth. So good stability in this plane here, and varus valgus. Now we'll close the capsule.